Okay, so um, one of your modules that you do is lifespan development. I think it's about Unit 14. It follows the anatomy and physiology unit. And obviously part of lifespan development is death. It's the end part of our lifespan. And obviously it's something that's going to be there for all of us. And we look at death in very different ways culturally across all nationalities. So in most societies, death is not viewed as the existence between the spiritual body. It's believed to live on. People in the UK tend to be death avoiders. So in other words, it is a subject that's quite taboo. We still don't like talking about it. We all feel very uncomfortable talking about it. So it is a subject that we try to avoid. And we're also kind of known as the death deniers. It's changing slowly because we've got a lot of knowledge there now where we're saying actually the more we talk about death, the less stressful it becomes, and the more we plan about it and the more we accept it, it helps with that grieving cycle and all the other bits. The evidence is there now to say, look, we can't avoid it. It is something we should be planning at an assessment stage, because what we don't want to be is in a situation where we end up with a bad death. And anyone that's done end of life training, anyone that's working towards gold standard frameworks will have heard the term of the good death. You'll have all have heard the term, what we're aspiring to achieve here is a good death. Life expectancies increase throughout the UK, so we are definitely an aging population. And obviously we've all experienced it through COVID and stuff, where we've had a lot more death than we usually do. Issues determining death. So technically what we're talking about is when somebody's brain dead. So it's a person whose brain is dead with all the electrical activities in the brain that have ceased with a specific period of time. This includes both the higher functions of the lower brain stems functioning. So in other words, we're completely unresponsive. The organs have all stopped working, and finally the brain stopped working as well. So advanced directives and living wills are designed to be fulfilled whilst the person is obviously still alive, and it helps us to kind of come to terms with some of their wishes and wants. So advanced directives are legally binding. So if you have got advanced directives, it makes it very clear on what to do. Living wills can be contested. So again, slightly different processes in law around those two ways in which they're designed. A lot of the advanced decisions are around treatment, consent to treatment, and one can argue that the do not resuscitate orders are part of advanced directives and decisions. Across the world, obviously, there's lots of different things around death and the way that we look at death. I think it was about 2000, in year 2000, the UK Parliament had a debate about our legal stance on assisted suicide in the UK. Obviously, it got overturned because they felt that we weren't quite yet there. But we know that there are other countries out there that will do assisted suicide. And equally, we know that suicide became decriminalised 10, 15 years ago to reduce the stigma around suicide as well. Equally, we know more people die in hospitals, and again, those advanced planning stages should be there. So the living wills or advanced directives are legal documents. Obviously, you need to have capacity to make an advanced living will, but anyone can make a living will at any time. You can get these off the internet. I don't know how reliable they are if they're not endorsed by solicitors, etc., because we don't cover that part of the law. But ultimately, advanced directives go through a legal process where the living wills just merely explain these are what people want and their decisions. So you need to read your home's policies around the evidence in which you would use. So we do have the two in nursing. We have the advanced directives. We know that they're a legal framework, and we do accept living wills. The reality is, when you come to use them, you need to read your home's policies and procedures on what you can do with them, because again, different services will have different ideas on those. Euthanasia isn't a thing, obviously, in which we accept in the UK at the moment. I think it will eventually come in. I think it's quite an emotive subject, the option to die. We have it almost, if you look at the gold standards framework. So if you have a terminal condition and you have less than 6 months to live, you can go on the gold standards framework, you can withdraw from medication, you can withdraw from food and fluid. So in essence, that's some kind of a euthanasia in my eyes, because we know the moment we stop giving somebody food and fluid, we are assisting them in the dying stages. So we kind of have it there. Obviously, that is obviously, it's got to be agreed with 2 doctors and signed off. So it's quite difficult at the moment. Obviously, what we're trying to evolve is a good death, and a good death involves patient comfort, supporting loved ones, and making sure that everyone around that person understands what's going on and trying to meet the needs. And that's why advanced decisions to living wills are so important. You know, the right to, you know, your care, your treatment, which was the legislation that came out in the last few years, your right to choose your hospital, your right to choose the treatment that you have, your right to refuse to take medications. It's all there. There is one problem with all of that, and that's the Human Rights Act. So who can tell me what the conflict is under the Human Rights Act is? What does the Human Rights Act say? Everyone is entitled to the right to, you know? What do you think it says? So everyone's entitled to the right to
make own decisions.
Nearly. So it's everyone's entitled to the right to life. And of course, in the Human Rights Act, because it says everyone's entitled to the right to life, it's quite difficult, because actually it says we should be doing everything we can in our powers to preserve life. So actually, we've got a piece of law that says you have to do your best to preserve my life. Equally, we've got advanced and living wills now that says otherwise. So it's very conflicting and can be quite difficult. And like I said, on the grounds that you've got a terminal condition, so an incurable condition, and less than 6 months to live, you can go onto a palliative care plan or an end-of-life care plan. Now, end of life doesn't necessarily mean you're going to die immediately. It normally means within the next 12 months. So there's a prediction that your life will end within the next 12 months. And therefore, you can go onto a palliative care plan. We can look at pain reductions and a way of dying with dignity. So that's looking at treatments and medication. The problem that we have with that is equally people's rights and values, medication and cultural differences. So again, there's some religious or cultural groups that won't have the pain relief because of spiritual beliefs and the fact that they're seen as toxins and impurities to the bodies. So it can be quite difficult. Equally, right to die at home, or the right to die in a hospital or a hospice. So choosing your location can be quite tricky as well, because again, it's based on, is it practical? Do you have people there to help you? So within your services, do any of you do end of life? No. Have any of you dealt with end of life?
We are.
Oh, yeah.
Okay, so hopefully, if you do deal with end of life, you will have seen palliative care plans. You'll see the end of life care plans and what they look like. You'll have seen the DNRs, the red cards that will show that. If you're not used to end of life, I highly recommend that you go back to module 1, week 1, module 1, go to the assessment tools and look at a palliative care plan, because the end of life care plans are part of that assessment planning tool. And equally, I think in the Canvas app, I have put a link to the gold standards framework. So when we talk about end of life, you must be able to quote the gold standards framework, because that's what underpins best practice and evidence-based practice when we look at end of life. So part of what we need to do is address attitudes towards death. So that's our own belief systems and values, and that of the others as well. If you've dealt with lots of end of life in care homes, I've seen the good, the bad, and the ugly. I've seen some wonderful passings, and I've seen some absolutely hideous passings because of family members. And with family members, you see some loving family members, and you see some family members that you've never seen before in your life, and it becomes very emotional quite quickly. And part of the nursing role is to have a very clear attitude towards death, and to be able to talk about death in a very empathetic way to support people to come to terms with it. And part of that is accepting other people's spiritual beliefs and their systems, so some of their practices and some of the things that happened there. And for us, it's about making sure we look after ourselves as well, because in residential and nursing homes, probably more so residential into nursing, these people can be with you for 10 years plus. And when somebody passes, it can feel like losing a family member because you've got that bond with them. So making sure that you're aware of your own well-being there. And again, we're looking at some kind of supervision or some kind of support for people just to talk about their feelings. And in a lot of homes, what tends to happen is you attend their funerals. I don't know if that happens in your homes. You attend the funerals? Yeah. And we do that to help us with our grieving process and out of respect. But again, could you imagine in a hospital attending funerals in a hospital? You just wouldn't have the time, would you? And there is this feel, isn't there, that in nursing care, in residential and nursing homes, when somebody dies, there should be a period of time where we let the room settle and we get to clean it and all of that stuff. But the reality is it's a business, and somebody moves into that room probably the very next day or that afternoon. And again, it's because it's a business. So trying to help people come to terms with the fact that actually, people need care, and that bed is there for people to have care. It can be quite a difficult thing for people to come to terms with. So we need to be thinking about our own attitudes and value belief systems towards death. Equally, what tends to happen with our attitudes towards death, the older we become, the more we think about it, because we all have this kind of feeling of life expectancy upon us. So the older we get, the more in the forefront it can come. And again, you can see here, obviously, middle-aged people often fear death more than young people. And I think that's because young people, when we think about death, we protect young people quite a lot. And this is quite important for suicide awareness in young people. So think about the first time when you was a child, you experienced loss. Now, it could be a pet, or it could have been a family member, and try and remember what you were told. Okay, so I want you just to think about your first experience of loss. So it could be a pet or it could be a person. I want you to just think about what was you told by your family. Does anyone want to share?
Yeah, it was my granddad, and they've told me he's gonna be an angel and he's going.
Okay, so that's lovely. So he's an angel, he's going to heaven. Wonderful. Making it a really lovely place, making it sound really nice. Good. Okay, anybody else want to share something that doesn't have to be a person? It could be your first pet or something. Or one more person to share. Dora, have you got a story?
I've got one.
Okay, Jessica, yeah.
No, it's Sam. We're both together. Sam.
Oh, okay, so it's Sam. So Sam.
It's actually
yours?
about Jess. I had my first ever hamster. And,
Okay, so what was you told about your hamster?
Well, Jess actually killed it. She put it in a bucket of bleach to see if it can swim.
Oh gosh. Okay.
Yes.
And is Jess sitting there? Is she quite red-faced now?
I am.
Yeah,
Yes,
she
I'm
is, yeah.
laughing.
Luckily, we can't see you. That's fine. You haven't got
She
your
was only
camera on.
4 at the time, so
Oh, bless her. So what was you told, though, by your parents?
gone to a better place.
Right, okay. So again, with pets, we tend to go, look, all dogs go to heaven, all animals go to this wonderful place. So as a child, our image of death is really positive, isn't it? We actually are told these wonderful things about death. We're told how lovely it is, how peaceful it is, how we're going to meet all of our people that we've never seen before, how they can turn to angels. So if you're a young person, why would you be afraid of death? You wouldn't, would you? Because it sounds such a lovely place. And the problem we have with that is young people and suicide. If we make death sound really exciting, there's no fear or consequence, is there? So actually, what recent studies have shown around young people is the fact that we need to be a little bit more honest about when we die, we don't come back. There's no returning. This is a forever thing. Because actually, we need to learn quite early on that this isn't something we can come back from, especially when we look at children's mental health and adolescents' mental health and beliefs around suicide. You can end up with this wrong perception of death that actually it's not that bad. It sounds fun. It sounds really nice. Because why would children know any different? If we're telling our children it's a lovely place and everything's going to be wonderful, why would children have a different belief system? And there is a lot of evidence that's come out of that. I was pretty gobsmacked when I was sitting on a suicide course being told that. But when I sat back and we all talked about our first experiences and we were all told the same thing. And actually, if we do make it sound wonderful, there is that. So there is this kind of middle ground, isn't there, that we need to come to around death, which is accepting people's beliefs, but also keeping it real, make sure that we're safeguarding and protecting people. And obviously, the reason I think more people fear death as the older we get, because we realise there's no Santa Claus, and we do realise that actually there is no coming back from it. Sorry if you're a Santa fan, I don't know, no spoilers there. So we just need to think about it, especially when we're talking about mental health and we're talking about maybe people that have got spiritual ideology. We've got people with already altered perceptions. We've already got people with suicidal tendencies. What we don't want to be doing is glamorizing something. Equally, it does need to be appropriate. So we need to think about it. We go through the death, the grieving cycle. So Ross's stage of dying, we obviously all go through the 5 stages there. So we've got denial. It can't be me, you know, it can't be, why is that? Sense of anger, why me? We go to that bargaining stage. If I could just have this, if I could just do that. We hit that depression bit with the withdrawn, the crying, the grieving, and then we kind of come to some level of acceptance and that sense of peace. So when we think about our Bob, who was our case study, would we tell him that he's dying or not? And we look at those ethical principles. If we don't tell him that he's dying, we can miss all of those stages. He's got no chance to go through this and come to peace with what's happening, has he? So again, another one of those, does it more harm than good, or the right to know versus the right not to know? Obviously, around the denial part, we kind of need to have some strategies there. We need to kind of have some things that supports them. And it's not just obviously the people that are dying, it's the family members as well. And I think it's about having those open discussions. And when we can have those open discussions and those advanced decisions, and we can try and aim for that death, it does make it a bit more real. It kind of makes it feel a little bit better. And obviously, around the denial bit, you're going to have those times when you're dealing with those heightened emotions and that anger and that hurt, and obviously it can be quite frustrating for them. Looking at the way that people die, so 50% of people die in hospitals, 20% die in nursing homes, and the rest die at home or in other areas. So again, a multitude of places where people can die. So looking at grief, looking at the emotional numbness, separation, anxiety, despair, sadness, loneliness. Grief is quite a complex emotion. And equally, when we're looking at depression and anxiety, we tend to say somebody can stay in that state for up to 2 weeks, but if you've got prolonged feelings for more than 2 weeks, you move from grief into depression and anxiety, which becomes a treatable condition. So ultimately, when we have a passing of somebody, and if we've had those personal experiences, in the now we tend to focus, we tend to pick ourselves up and get through what we need to get through. And that's that emotional numbness bit. And that's normally the planning of a funeral or trying to do those goodbyes. After that, so after the funeral, tends to be where it hits people. And that's where it comes to that disbelief, separation, that anxiety bit, because they're not there anymore and we realise, and that whole planning bit's gone. So we're now focusing on that sadness. So thinking about advanced decisions. So if you think about Muslims or other religious groups where they bury their bury the deceased within 24 hours, that's quite a quick cycle to go through, isn't it? In the UK, you know, my recent experience was at least 4 weeks from somebody that I knew from passing to the moment we got into a chapel. So we seem to have quite a long, drawn out process in the UK, which make it quite difficult because actually you don't start that despair cycle until that's done. So we need to be mindful that during that process, we are going to have people going up and down. And it does feel like a roller coaster. It doesn't mean we need to be diagnosing them with depression and anxiety disorders and stuff. What we need to be looking at is normal things such as, are you eating? What's your sleep hygiene like? You know, are you self-caring? Rather than let's start pumping you full of medication. Cognitive functions obviously can be impaired. Communication is obviously key here. Supporting people, just to allow people to talk. Prolonged grief is you can see here between 10 and 20% of survivors have difficulty moving on after 6 months. So actually prolonged grief is, in the kind of scale of things, it's quite a minor thing, people that go through prolonged grief. You know, we are designed to move on as quickly as we can and support people. And what we know about moving on is, if it's planned, if everything is done in line with the person's wishes, it helps that grief process because people feel that they've done what they need to do. And that's why those advanced decisions are really important. So disenfranchised grief is obviously where they can't mourn more openly. And that could be things where they're trying to hide things, or they're looking at the stigma, or and I've seen it quite a lot with the elderly, where you've got LGBTQ service users where they've not been open about sexuality and they've said they're brothers or sisters, and they've had to hide those relationships. The dual process model looks at loss orientated, so we're looking at the stresses here, factors so affect grief at work, both positive and negative. You can now look at other areas around behaviour, so affecting the way that they think and their cognitive processing, and just making sure that they're obviously sleeping, etc. You can have a change in identity, mastering new skills, and obviously effective coping involves cycling between coping the loss and moving forward. So the impact of death and surviving individuals is strongly influenced by the circumstances in which death occurs. So things such as more traumatic death, etc., causes more post-traumatic stress disorder syndrome. And again, we'll look at PTSD later on. Equally, the prolonged dying stage can be really stressful for people. So those that have worked in end of life, I'm sure you've all seen it with people that just keep hanging on and hanging on and hanging on and hanging on, how stressful that can be for the family, and it can be quite horrible. One of the saddest things I ever witnessed, it was an English teacher. She was about 89 and she was diagnosed with all over body cancer, and she was in pretty much respiratory distress. She didn't want any medication. She wanted to die without pain relief, and she was in agony for about 2 weeks. And literally every member of staff that went in to see her was walking out in floods of tears, because what we were seeing was just this deterioration of, you know, this wonderful lady who had been a school teacher and loved by everyone in the community, but this prolonged death was just awful. So I think we've all got stories. If you've worked with end of life, you've got those particular stories that sit with you. So it's obviously important to recognise those. Cultural diversity, we've already spoken about that anyway. Obviously just understanding those. So if you do have cultural diversities, making sure that you've done advanced decisions and wills, it's really important, including what to do with the aftercare of the body. So it's important that you know whether or not you're going to be doing the last offerings, so whether or not you're going to clean the deceased, what your protocol is in your home. So if you've got nurses there, are they able to do the death certificates? So nurses can now sign off death notification forms. They can pronounce the death, or have you got to bring a GP for the GP to come in? So knowing your protocols is really important, especially around cultural diversities, because if you've only got 24 hours from the person dying to the person being buried, that doesn't give you very long to sort things out. Choosing life partners, statistics aren't so great for us men. Women are outliving us, no surprise there. So 5 to 1 on the ratio, women live longer than men. I think the national average at the moment is a 10-year life expectancy difference between men and women. So women naturally live longer than men. So again, just thinking about what it's like to lose a life partner, and especially for people that are left behind, that whole support in the nursing care system. And this is where your social prescribing skills will come into force. So such as you have your charities or organisations in which you can pass people on to. So I think there's like Cruise out there, which is a charity that deals with loss and bereavement, looking at organisations and where you can refer people on to. Obviously, people mourn in different ways, and people are the way that we deal with the deceased is differently. Approximately 80% are buried, 20% are cremated. I don't think that's probably not right now, so I wouldn't use that stat. I think a lot more are cremated now than are buried. And obviously, people mourn in very different ways. And one of the things we're accused of as nurses is appearing to be quite cold-hearted, because everyone's crying and we're the ones that have to hold it all together, and we can be seen to be quite cold, although that's not the case at all. It's just the fact that nobody needs the care assistant, the nurse, standing there crying along with everyone else, because actually you're meant to be that glue holding everything together. Although I would say it's probably very rare that I don't shed a tear when I'm with somebody. I think it's okay to show that humanistic side, but as long as it's not all about you, obviously you're meant to be there for them and the family members. Right, so that's the first presentation. So we'll just move swiftly into the second one. Okay. So, despite best intentions, living high quality end-of-life care in an acute environment is difficult. And when we talk about the acute environment, we are talking about more the hospital settings than necessary care homes. And that's because obviously in the acute settings, face a lot more challenges than residential and nursing home. And that can be difficulties such as identifying the approach to end of life, conversations and further treatment choices, looking at different courses of actions that tend to be activated in our activities and treatment. So 80% of people would prefer to die at home, with only 45% of people in their usual places. So we've still got a fair amount of work to do. And if you think about where you would like to die, or the people that you look after, it can be really difficult. So in a residential setting, a lot of the times you have to move the person on. So you have to move them either to a hospital or to a nursing home. And actually for them, that can be really traumatic, especially considering they consider those last years in a residential home their home. So it's about those advanced decisions again, and looking at, if you were to meet the needs of the people which you look after, have you got the right skill sets around you? So have you got the syringe drives? Can you get in palliative care, help support, or is there anything else in which you can do to support that? One chance to get it right. So in death, there is only one chance to get it right. So that's why it's really important to have the discussions with people, make sure that you have advanced decisions and advanced care plans supported, and make sure that people understand what the dying process looks like and what the final days and hours looks like. And in the video for this, I think there is a video that talks about the dying stages, and I'll upload another one that I did for my organisation. At the beginning of COVID, we talked about what the dying stages look like. So we talk about a week, 48 hours, a day, and the hours. And what you tend to see is the organs shutting down, the body deteriorating, and then you should be able to predict pretty much when the end of life is going to happen within a 24-hour period. And that's really important, because if you miss the signs of dying, if you miss those stages, you rob people of the opportunities to say goodbye to people. So it's important that you can spot signs of deterioration and the signs of end of life coming, because within the last stages, people want to be there. And I don't know what your policies are in your services. What I tend to see a lot of the time in residential and nursing homes is a member of staff will sit with that person. If you know that they're dying within the last 24 hours, that happen in your homes? Does somebody normally sit with somebody?
Yeah, we used to sit with them.
Yeah, it's quite common. A lot of the time, the carers will sit there with people. Again, completely unpractical from a payment point. You know, it's really difficult to fund that and staff that. So, as we've said, people in their last year of life looks at its prediction of 12 months. So what we're saying is the gold standard framework indicates the recognition for end of life care. Now, the gold standards framework isn't a mandatory thing in which organisations have to do. It is just, well, I don't say it is just, it is the evidence-based practice. It is seen as the right model to be using. So I highly recommend that you have a look at the gold standards framework. I think there's a link on the site anyway that I've put there. Your services, if you are offering end of life, if you get the gold standard framework, you are able to tender with the NHS and get more end of life packages. So again, it's a quality kite mark they look for. So it's something that I definitely would recommend people to do. In the gold standards framework, it gives you the policies, the procedures, the paperwork, and it gives you, as you log into the gold standard frameworks, it gives you a fact sheet that you can give to family members. So that's part of our role, giving out education. It talks about supervision, and it talks about the patient. So it talks about all of the things that that person needs to know. Because the reality is, we know we're death deniers. We know we don't like talking about it, but we need to be told the truth, don't we? Life's about informed decisions and informed choice. Therefore, you need to tell me everything. So in here, it looks at what it looks like, you know, the treatment, when we can stop your medication, when we can stop food and fluid, and obviously those dying stages. And then obviously it looks at other things. Equally, we need to consider about organ donating and skin donating, etc. So I think we're now at the state where we've opted in unless we opt out for donors. So again, some people may not be aware that we're now all organ donors unless we opt out. So we need to look at what people's choices are and obviously respect those. We've already talked about the end of life discussions. Lots of evidence around it. All of the evidence points to is a helpful thing. There is very little to no evidence that says having a discussion about end of life is harmful. In fact, it's all of the opposite. It all concludes that having those end of life discussions with people is a really supportive thing. So in box 1 here, you can see it's giving you some suggestions about how you can start those conversations. So, for example, what do you understand about what's happening to you right now and your health? Do you want to talk to me about it? Have you thought about what's going to happen to your health in the future? Do you have any strong feelings about your treatments, or any that you would or would not want to receive? And that kind of gives you a nice opening into the DNR stuff, etc. So having those conversations is really important. And I personally believe if you do it on admissions, it doesn't look so scary because it just looks part of the formal admissions process. You know, it doesn't look like you're doing it because they're dying. If somebody says to you, can we just discuss your end of life care? First thing you're going to think is, I'm dying. And that's not what we want people to think. You know, we just want people to be thinking about their future and thinking about those decisions. You know, where do you want to die? Where does, what, you know, who are we going to contact? Where are you going to go? So looking at best practice then, obviously we need to look at how we get people onto the end of life care plans. And this is obviously done via doctors who decide that there is an underlying health condition there. So we look at, we feel that there's an underlying condition that's not going to see you live beyond the 12 months. We can review current treatment and care based on your goals. So what is it you're looking at? So that makes it outcome focused. We have an agreement with the patient regarding further treatment. So for example, do you want chemotherapy? Do you not want chemotherapy? Do you want this operation? Do you not want this operation? And people tend to feel like you're giving up at that stage, and that's not it. You've just hit that acceptance. You know, if you've come full swing and you've done that grief cycle and you've gone to acceptance, you may have already decided, look, I don't want any treatment. This isn't what I want. We need to think about any interventions to support the living will. And nursing interventions to support living wills could be things such as pain relief. It could be making sure that we've got the right people here for you. It could be making sure that we've got the right spiritual guidance, whatever it is. And we can need to look at interventions that are no longer helpful. So, for example, are you on medication which actually it's causing you now more harm than good? So is there any therapeutic benefit of you carrying on taking this medication? And obviously those conversations will be had with the doctors. There'll be some medication which will be life limiting. So if they stop taking that medication, it can reduce the time. But the doctors will normally have those discussions. So for example, if somebody is passing with cancer, they may turn around and say, look, they've got COPD medicines, they've got this medication for heart condition. You know, you really need to be taking that now. You know, if what we're saying, this is incurable, we've agreed that, okay, by stopping those medications, you are probably bringing the inevitable forward another couple of months. Some people will be happy with that. Some people obviously won't want that. You know, they may want to feel that they want that additional time. Again, it can be quite challenging discussion. Your role at level 5 is to facilitate those discussions, just to have those and explain to people, look, there are choices here. And obviously, all discussions and treatment plans should be well documented. So again, that should just go straight in the care plan. Advanced care planning. Some patients may consent to the outcomes of their discussions being recorded as part of the care plan. And again, things that you need to be thinking around are wishes around organ donation and specific around funerals, and options looking at other things. Advanced care plans can range from recording their preferences and values. Also part of a legally binding advice decision, the refuse to treatment. So that's the right to refuse treatment is anything to preserve your life. So there could be ventilation, it could be resuscitation, and they're obviously legally binding. What you tend to find is family members start to appeal them. The people that they're designed for tend to accept it. Family members start to challenge those things. So just making sure that capacity and consent's there, that they're able to understand. And equally, you may need to appoint a lasting power of attorney. So somebody in the stages where maybe you lose that consciousness, who is it you want us to talk to make sure that these decisions are being upheld. I don't know if any of you have been in a situation where families start arguing. It can be incredibly stressing. It's distressing for the member of staff that's got to coordinate it. Equally, you know, if we think that the last thing to go is our hearing, or that person that's lying there, it's just pretty poor taste. So making sure that these are all in place and that people have bought into it before they go into a room does save a whole heap of pain. Following assessment referrals, specialist palliative team should be considered. So complex system control. So if we think somebody is going to be in severe pain, then obviously specialist palliative teams need to be involved. And that's more because of the controlled drugs, looking at the morphines and the oral morphines and those end-of-life drugs that control the anxiety and stress and all of that lot. And then normally then given through the syringe drive, the T34s. And again, we'll show those. And when I come out, you'll have a practice of those because you should need to be able to do those. And equally, just to help manage psychological and spiritual issues as well. If people are being discharged, obviously just making sure the discharge plans are being done. People are aware of the DNRs. Making sure that if you're referring people on, they've got advanced care plans and things that you've done. Nobody wants to have that discussion over and over again. Equally, just making sure that any social prescribing that you've done, any kind of charities recommendations or any referrals that you've got for them, you've already done. And equally, the electronic registers, they're not code. I don't think the electronic registers are working too terribly well at the moment. We do have what's called the spine in the NHS, and that's the one where all the GPs and the hospitals link up to a main computer on our health records. Definitely improving, but normally the DNRs would sit on there as well. Just to make sure that if you do discharge somebody, that you do make sure that they have the red original DNR form there. So in the last weeks and days of identifying the death and possible outcomes, we just need to make sure they're as comfortable as possible, that they have choice and control around their life. We should be looking at the quality of life rather than quantity of life. And we need to be looking at the gold standards framework. So that's where we start to look at the factors around reducing food, fluid intakes, taking them off medication, and obviously just supporting a pain-free dying stage. So we just need to think, if somebody is going to be bed-bound, who's going to, and making sure that the comfort's there, and just thinking about that. Leadership for Alliance for the Dying Care of People identified 5 priorities, and that's obviously the possibility of death is recognised and communicated. When my mum passed, she was given a week and she had terminal cancer, so we didn't really get a lot of time. So making sure you have that information, being sensitive with it. It can be really difficult on the language in which we use. So just thinking about how you're going to hold those conversations, because they are quite difficult conversations to have. Thinking about the dying person and those identified as important to them. So making sure you're keeping the important people in the loop. And that's why communication consent is really important. So again, advanced decisions, making sure we know who it is. The need for families and others to be identified. And that's just around making sure that people are being respected and obviously being treated as fairly as possible. And then 5, that an individual care plan, which includes food, drink, symptoms control, psychological and spiritual support, is all agreed in advance. Okay. So again, you kind of want that all as soon as possible. In hospitals, that's really tricky, because in hospitals, you don't get a lot of time with people, but in care settings, you have a lot more time. Other important considerations, looks at how you're going to improve accessibility for district nurses. You need to align any cooperations with ambulance services or agencies beyond that. If you've got people dying within your services, who are the community-based palliative care teams or rapid response teams? So they're the ones that could come out, maybe the syringe drive slipped, or the oral morphines needs to be up, or something's not right. What are we going to do there? If they're going to be placed in a hospice or the hospice at home team, who's going to do those? Looking at then extend hours of pharmacists. So you want to make sure, if you are dealing with end of life, you have a sufficient supply of end of life drugs. And then obviously looking at any other organisations or contact details that you need for services. You're not going to be doing discharges in yours. The other clinical things to think about then, so medication, just to relieve pain, nausea, diarrhea symptoms, respiratory secretion. What you tend to see towards the dying stages is quite a lot of fluid comes out the mouth. So again, just think about your positioning in the bed, just to help clear that airway. Will you be doing suctions or anything like that? And then if we're looking at the opioids, are they going to be given by the syringe drive, by the subcutaneous route, or is it liquid? What you tend to find with the dying stages is up until about a week, the oral morphine via liquid, via the oral route is fine. Obviously, what then happens is that the gag reflex stops and they find it difficult to swallow. So then that's when you would probably revert your medication over to a syringe drive. Patients should be supported to eat and drink if they're able to, but obviously decisions to assist hydration and nutrition needs to be made. So again, that's an advanced decision. So yes, we could do extended feeding techniques. We could use pegs or nasal tubes to still get those fluids and nutritions in. Is that what they want? If you're on the gold standard framework, you tend not to. We tend to withdraw. And fluids, we tend to withdraw in the last 24 hours. So knowing those dying stages is really important, and you tend to know when it's in the last day or so, because you get the cyanosis, the kind of the blueness comes, and you get the agonal breathing, so that graspiness starts to come, and you can generally hear a bit of a rattle. It's a bit like a fluid on the lungs. You can hear that. For those that have dealt with end of life, that all sound familiar?
That rattle, yes.
Yeah, you can tend, and that rattle normally, when the moment you start hearing that, it is like a rattle, isn't it? It's a strange thing. It's not a wheeze. It's definitely more a bubbly kind of thing that you'll hear that tends to indicate 24 hours max. I don't think I've really heard that rattle go on for more than a day. It's not, there's no real evidence to suggest it could go on, but it tends to be within the 24-hour period. And you tend to see the skin change as well, don't you? They tend to go a bit more grayer and a lot more chalkier looking. And others then, obviously things to consider there, regular monitoring, goals and treatment, carers' concerns, so just making sure that the care staff are obviously supported, and then looking for signs of recovery. Now, it's weird that we put signs of recovery on there. there are occasions where people who are on end of life seem to bounce back. Nobody knows why. They make you look like a liar. You tend to say to the family, it's going to happen. You think it's going to happen. They seem to have a cough. They sit up and they're absolutely fine again. And I'm sure, I don't know whether you've been through those in your services where you think someone's going to go, but actually they've come back. So again, at that point, if you do get signs of recovery, we need to think about how we're going to plan for those. And it's important to say to people, look, this is common. Towards the dying stages, people look like they're recovering. And what you tend to see is going downhill, they do this little bit of recovery, and then they drop again really quickly. Have you all seen that?
Yes, we have a lady. Obviously, she's not eating, she's not drinking. Obviously bedridden. Then the GP stopped all the medications. Then she comes back, and then she's after a month, she's now eating, she's drinking, and she's sitting. So
Yeah.
she's much more healthy without the medications.
Yeah, absolutely. And the problem is for family members, they could start to lose trust in you because they're going to go, oh, you don't know what you're doing. So it is important when we give this information, it's important to say to people, look, just because they are on end of life doesn't mean they're going to die. And yes, the body may be looking like this is going to happen. However, it is common that they pick up. There is always this little blip. It doesn't mean we've all got it wrong. It just, sometimes people tend to hold on for a bit longer. So just being aware of that. So looking at some of the medication there, looking at pain, it's normally the oromorphs and the morphines. You don't really need to know about the starting doses because this is designed for GPs, this slide. But again, for pain, it's normally the morphines. Midazolam tend to help with confusion and anxiety, so that's quite common. It helps with the hallucinations. So a lot of people state when they die, they see their loved ones and relatives. There's a recent study that's come out to say with the dying stages, we hallucinate, we tend to project what we're missing or thinking about, and therefore it's normally our loved ones or somebody we've not seen for a while. And that's kind of the explanation to why we see people towards our dying stages. Obviously there for nausea, we've got things like the haloperidol, very typical stuff. And again, for respiratory secretion, you've got those there. And then obviously for the breathlessness, you've got the morphine or the midazolams again. So normally what you tend to see is a combination of 2 or 3 drugs, which is the morphine, the midazolam, and something for either the secretion. And again, depending on how they're prescribed, most of those drugs can be mixed in the syringe drive and it can be given there. But again, you just need to make sure that that's there. They're your normal common end-of-life drugs. Don't need to worry about that. Right, marvelous. So, are there any questions about end of life? No. As I've said, what you need to, or what I need to see for assessment is an end of life care plan. So I need to see that you've produced an end of life care plan, and that you've taken into account people's needs, wishes and wants. And yeah, that's and obviously if you're in a service and you don't do end of life, you'll need to do an example care plan. So you'll need to simulate one. Okay, so let me just stop that recording.